Dr. Prayag, please.
Good morning, everybody. I am Dr. Sudeep Verma, working as a consultant pediatric cardiologist at KIMS Hospital, Hyderabad. Today, I am presenting a very interesting case of ASD device where the persistent cause of chest discomfort is there. And when we come to the cause, we'll know the cause was in our front of our eyes, we were unable to get it. And this diagram also correlates with that the mystery will resolve, mysteries unfold as we go further. So the clinical detail of the patient, 6-year-old, asymptomatic, weight 24 kg, diagnosed to CAG when evaluated for murmur, when evaluated for RT and VO. Moment examination revealed wide and fixed split S2 with 3/6 ejection systolic movement left upper sternal border with no chest deformity. The chest X-ray that shows prominent RPA, cardiomegaly with loss of right heart border. So the ECG that shows the typical Prochetas as well RSR dash pattern with right axis deviation. Is the echo images that shows the in subcostal as well as the parastern apical with the VSD measure around 9 into 13 mm. It's an oval shaped defect when we assess the all planes, and then this is the NFAS that shows the size of the defect and which measures around
Good
11
morning.
into 14, and the
Aorta
intended
ventricular
device we thought will close with the 16 mm plug. So procedure detail they taken for device was under T guidance, PA pressure was normal, 10 French hook delivery sheath was taken, and 16 implants of septal occurred deployed, and even after the device with the sinus rhythm was there.
As mentioned
This is the
earlier,
left innominate vein injection given. Why we give? Because we thought the right head border is not seen and it was difficult to enter the left innominate. So we gave. So we didn't find out any abnormality. And when we thought he will do the device, so we were unable to enter in the left upper pulmonary vein, so that we went into the right upper pulmonary vein and we deployed the device on the right upper pulmonary vein. You can see the one of the first two which was present here, what we missed, there is a loss of right heart border, unable to enter left upper pulmonary vein, and the defect device after the release, it's like a RA view, that means it's a rotated heart. So this is the post-procedure echo. There is no problem with discharge. On day 2 of procedure, aspirin started, but she's continued to intermittent atypical chest pain. Which is not related to exertion or anything, even after 6 months. So no pericardial collection, echo, or erosion on echo. EC shows no signs of ischemia or strain. We given painkiller antacid, but atypical chest pain process. So for with that in mind, whether we are missing any coronary abnormality with the CT scan
other
that shows no
putative
coronary compression, normal and
mechanisms which have been
course of
hypothesized
the
but never
end course of the
proven
coronaries and labeled
is
as
that
normal
some authors
cities.
believe it's a
So as
congenital
the
defect
old
of the
saying, the eyes
elastic
don't see
lamina
what the
of the
mind
aorta
doesn't know.
itself.
So we started thinking reverse.
Yet
When
some
we did,
other
why we
authors
did
believe
CT
it's a
scan?
mesocardiac
So we come
cystic
to know,
structure
is there
which
anything? So the X-ray shows typical pattern. Is a typical pattern that is known as the drop, teardrop heart, and this is the typical of something which is the diagnosis here. So innominate vein injection, SVC orientation change because of the clockwise rotation of the heart. So if you see there is an air present within in the AP window area between pulmonary artery and aorta, loss of right heart border, levoverted heart, and the left heart border is very prominent. And device like ROV because of the counterclockwise rotation overlapping this. So this is the typical of the absent pericardium syndrome. So when we retrospectively again see the CT, we come to the all findings are present. Air below the heart also is seen, and on CT also air is seen between PA and aorta. So this is the in general the absent pericardium, which is more common on the left side. Partial is more common than complete, and the cause for symptoms are clearly due to laxity of cardiac support, unstrained and excessive mobility. Chest pain, which is the commonest symptoms, but the X-ray is the key and main investigation. If in doubt, we can do the MRI. And absence of mediastinal shift differentiates from the other causes of mediastinal pathology. Coronary issues is because of the ST segment elevation, we'll see, or sometimes the king because of the rotation, we can find out. But most other causes are the partial defect, which is a foramen like that will cause a more strangulation and cause the ischemia. So treatment as prognosis, as majority don't need anything, only the foramen type where there is a herniation causing the strangulation of the structure that needs the treatment. Otherwise, no specific treatment is needed. So this is another patient typical when we thought the device is malaligned, but you see this is the typical air below the heart, air in that, and the absent right border with the levo rotation, no tracheal shift, no mediastinal shift, and this is the typical Snoopy sign appearance. That's why the first X slide that shows the Snoopy cartoon that related to the Snoopy sign of the absent pericardium, which we missed. And after 6 months, we did the
forms
reverse
abnormally
thinking
at the
like a
fifth.
typical picture or reverse case of Benjamin button or rewind button like a tape recorder. So these are the typical X-ray findings in all the absent pericardium. What are the
Aortic
better
arch during
findings? And
intra-atrial
here the diagnosis is in front of, or I will still be asking what is the diagnosis. This is like This cartoon typically denotes when we ask a pirate, what is your occupation? It's very obvious from his appearance. So treatment has been nothing. The message, pericardial agenesis can be missed easily. Atypical chest pain is common. X-ray is very classical. CT MRI can help. Difficult to enter pulmonary due to orientation. And orientation device may change. Confusion, ambulation, malposition may complicate if foundation is partial or foramen type. So thanks a lot, and I'm open for the questions.